So I want to welcome this morning a group of individuals that I've had the pleasure with working with for some time and more specifically over the last 3 years as we work together on a policy academy followed by in-depth technical assistance. I'm going to go ahead and introduce our three presenters this morning. So Elisa Stahlberg is coming to us from the Family and Child Health Division at the Vermont Department of Health, and where she serves as director. She provides vision and leadership for statewide family and child initiatives, oversees management of the strategic planning, operations, programming for prenatal to youth, young adult, all the way through budgeting, human resources, workforce development, and communications for the Division of Family and Child Health. That's a big role. Lisa's approach to the work combines her deep understanding of the community-based and statewide systems that collaborate to support the health of Vermont's family with her commitment to build partnerships and shared decision-making. She earned a master's in social service and law and social policy from Bryn Mawr College and has been working at the Department of Health, and we've been working together for quite some time, but she's been there since 2010. And our next presenter is Lindsay Barron, who's now the Director of Policy and Planning for the Department of Children and Families Family Services Division. Lindsay's been working in child welfare policy and practice for 14 years, and she supports policy development, implementation of new practices, upkeep of current policies and practices in Vermont's child protection and juvenile justice system, another big role. Lindsay also oversees the policy and planning leadership team with Family Services Division, which consists of policy, legislative communications, quality assurance, system of care teams, including foster and kinship, interstate compacts, permanency planning, and post-permanency services, and practice subject matter experts, prevention, child safety, staff safety, and domestic violence. Lindsay's training was a bachelor's and master's degree from DeCunes University. Sorry if I didn't do that right. And Lindsay's originally from a small town outside of Pittsburgh, but now lives in Colchester with her dog Ollie. And finally, this isn't as much, I feel like I need a much bigger introduction for you, but Ariel Bulak is a person with lived experience. She's a mother of 2 teen boys in long-term recovery. She's the executive director of Kingdom Recovery Center in St. Johnsbury, Vermont, which serves individuals with SUD, and she has been an integral part of our team on many different projects. So I'm going to turn it over now to our 3 speakers. Thank you.
Excellent. Thank you, Michelle. Good morning, everyone. Again, I'm Elisa Stahlberg, and I'm the Director of Family and Child Health at the Health Department. Can we get to the next slide? Okay, here's what we're going to talk about this morning really fast. Really, we're going to talk about this partnership, a multi-agency partnership, how we got here, what our purpose is. We're going to talk a bit about the family experience with the system of care. We're going to delve really much more specifically into the in-depth technical assistance project that Michelle mentioned, and talk a little bit about what that is and what our accomplishments are, and then have you help us think about what our next steps are. So next slide, please. I just want to acknowledge in this, this I think all of you know, but this is difficult experience, difficult content. Many of you have had personal experiences or worked with people with personal experiences of people who are impacted by substance use, maternal death, suicide, intimate partner violence. So please do what you need today, this morning, if you need to step away. And finally, I just want to take a moment to acknowledge all the Vermont residents who have died during and after pregnancy, their loved ones, and the communities who care for them. Next slide. Okay, I'm gonna pass it off to Ariel.
Hello. Can you guys hear me? Okay. So my name is Ariel Bolak, and I'm a Vermont IDTA member, and I also work with the PQC as a patient and family advisor to share my lived experience. And really, I just wanted to express the importance of wraparound services for those with substance misuse and pregnancy, it can be really challenging to have multiple providers and having to tell your story over and over and over again and not remembering who you told what to. And so having that wraparound support just eases that and makes you feel like you have a team of people supporting you. And it helps just reduce stress and not having to relive sometimes traumatic things over and over again. It's nice just to have everyone on the same page, really understanding you, where you're coming from, and just trying to support you. Um, Treating individuals with substance use as just a normal human, just like yourselves, is what really matters to us because we aren't any different besides our issues with substance use. And sometimes the way that we're treated, if we can be treated in a human aspect, it really can help us find our recovery and stay in recovery and be able to be the best parents that we can be. Um, so it's been such an honor and a privilege working with these teams, just being able to bring the parent voice and lived experience. So I thank you all for attending this, and I hope that it's a wonderful conference.
Thanks, Ariel. Next slide, please. So a bit of context, sort of how we got here. I'm sure many of you have heard this. Some of you even sit on the maternal mortality review panel. So there is a legislatively determined maternal mortality review panel, MMRP. It was established in 2011 by the Vermont legislature. It's a multidisciplinary team with membership across the state. It's chaired at the health department, but it is a shared experience. And we review all perinatal deaths from all causes, pregnancy through 1 year postpartum, in order to identify factors associated with these deaths and offer recommendations for prevention and other system changes. Next slide, please. So over a little more than a decade, we've been reviewing these all these deaths, and there's been a significant increase in maternal overdose deaths, with all deaths reviewed heavily impacted by substance misuse and related co-occurring issues. 90% of the deaths that we've reviewed in this period, 11-year period, have had a mental health disorder, and many have had multiple diagnoses. 61% have been impacted by substance use, and 11% died due to suicide. 46% of all deaths were the direct result of accidental overdose or substance misuse. So, and we've seen an increase in the substance use deaths over time. And so that's an underlying factor in all of this work that we do together. And just a quick note that most of the accidental overdose deaths did include polysubstance use. Next slide, please. And here's a new slide for all of us, really looking at the overdose death rate among female reproductive age and those who have recently given birth. And you can see that the overdose death per 10,000 estimated pregnancies has been climbing over time, and in 2022 exceeded the rate of those of reproductive age. And so these are really worrying trends, and this team and all of you are really working together to help shift this. Also noting, in Vermont, we have a small number of deaths, so a single death really could change the trajectory of this curve. So just take that into context as you look at this data. Next slide, please. Many of you, or all of you, hopefully know that the state does an annual survey called the Pregnancy Risk Assessment and Monitoring System. It's a look at individuals who have recently given birth, and it's done in most states, but not all states. and Vermont has been doing it for a very long time. The last year of data that we have is for 2022, and Vermont has among the highest rates of substance use in both pregnancy and in caregivers in the nation, and that includes tobacco, alcohol, cannabis, and other substances. And you're going to see this data a little bit later in the next presentation, and with a little bit more context. But as you can see, high rates of alcohol, cannabis, and tobacco in particular occurring during pregnancy, with real impacts on the developing fetus, and also on the family and the family system. Next slide. I'll pass it off for Lindsay.
Thanks, Elisa. So I'm going to begin with a high-level snapshot of the number of DCF Family Services Division open cases. This data includes children in DCF custody, the number of conditional custody orders we hold, which could be in-home with a parent or a relative, and voluntary family support cases with no court involvement. So this slide gives us a 7-year view of all of our open case types. It's critical to note the dramatic reduction in open cases over the last decade. This reduction is one of the most notable shifts in our division's history. It's also worth noting the significant overall decline in custody numbers over time. This reflects intentional shifts in practice, fidelity to our structured decision-making tools and identification of dangers, and our prevention efforts. And I checked this morning, so this morning our numbers are down even more. So there are currently 870 children in DCF custody today. Next slide, please. So the reason I gave you that context is I wanted that backdrop to help us understand how substance use is a contributing factor in custody for some of our youngest children. Although I want to begin by being transparent about how we gather this information and note the data limitations. So as many of you likely know, we have an extremely antiquated data system, and unfortunately, these numbers aren't pulled from a single checkbox in our system or an automatic flag. So instead, we generate a list each fall, every November, of all children ages 0 to 5 who are in DCF custody, and we share that information with our district offices. Staff then manually review each case and answer a short set of questions. So was any form of parental substance use a contributing factor in this custody episode? And then we ask a follow-up question, which you'll see in the next slide: was that substance specifically an opiate? Because it's a manual process, the responses rely on professional judgment of workers and supervisors, and there's some subjectivity involved. But still, this gives us a glimpse into the best available information we have related to substance exposure in the context of our open custody cases, specifically among very young children. I think the data trends are pretty interesting to see how those have changed over time. And we surprisingly have higher rates of substance use as a factor than ever before in our history. So again, this process is repeated every year. We follow the same steps, and it gives us the ability to track trends over time, even if it's not a perfect science. Next slide, please. So when we narrow the lens to opiate-specific involvement, over half of our cases are linked to opiate use in 2024. And again, similar to the last slide, this gives a glimpse over the last several years. It seems to suggest a gradual evolution in the preferred and used substances that impact caregiving and children's safety. Next slide.
So this data that we shared, and the data over time really was the backdrop in which we sort of all came together in this in-depth technical and the Policy Academy, and then the subsequent in-depth technical assistance project, which we're going to talk a lot about. But what we really learned from the data is that the second 6 months postpartum has been identified in Vermont as a period of increased risk for perinatal people with substance use disorder. And so really there's a lot of great care and important efforts that are happening sort of during pregnancy and in that immediate postpartum phase, but we have some pretty significant gaps and concerns with that later postpartum period, and that there's just pretty significant presence around of substance use in our pregnant and early parenting period, and that even folks who are stable on medication for opiate use disorder, some were flagged, some were who weren't flagged, and really there's just concerns across the board, and that our work is really to connect with all families to ensure that there are postpartum supports. Next slide. So that was the launch into this in-depth technical assistance project that the team participated. You saw a preview of this slide that Julie put together, and here it is again. So in January 2023, the National Center for Child Abuse and Child Welfare, or Substance Use and Child Welfare, invited states to apply. We had already been participating in about a 6-month policy academy activity, and we applied for the in-depth technical assistance activity. It was a 24-month project, and it was a pretty big team. You're going to see the partners in just a few slides, where the National Center provided support and expertise to sites through a TA model that matched the site's strengths, needs, and priorities with a change liaison from the National Center with that experience. And our TA expert was LaTanya, and she was amazing. I don't know if she's on today, but any of you who have come into contact with LaTanya just really know that she was really a partner in this work with us, and helped drive the train a bit and keep us all engaged and showing up at meetings, but really understood this content, and we're so just very grateful for her support and encouragement and help along the way. So we applied, and we began in March 2023, and that continued through March of 2025, and we're continuing to meet, and we'll talk to you a little bit at the end about our next steps. Next slide. So now I'm going to pass it off back to Lindsay to talk about our work together.
Thanks, Elisa. So this slide contains the outline and structure of Vermont's IDTA work with the support from LaTanya and the National Center on Substance Abuse and Child Welfare. We co-developed a detailed action plan, and this contains some of those high points. The plan helped ensure that our work stayed grounded in Vermont's real needs, timelines, and reasonable goals. And in true Vermont fashion, we probably articulated far more hopes and goals than were feasible within the limited duration of IDTA, though we did request an extension, which we were granted. And it gives us a good foundation for the work moving forward as well. Next slide, please. So like I said, our goals were ambitious, but grounded. And so overall, we wanted to build more family-centered systems, strengthen our cross-sector partnerships, improve our data infrastructure and how we're using data to drive decision-making, and reduce stigma and bias in decision-making. Every effort was anchored in equity and recovery-oriented approaches. Much of our work was guided by the principles of implementation science, and this is where having the support from a national center was really helpful. It started with assessing the current state of our systems and operations on the ground, mapping what's happening across the state, accounting for regional variations, identifying opportunities to bring greater consistency and stronger feedback loops into the work. Next slide, please. And as Elisa previewed, this is a list of all of the partners that were involved in our IDTA work, ranging from the various state agencies to providers, recovery supports, people with lived experience. And really, Vermont is just such a small and lovely state. And this is a glimpse into who all of those key partners were. And this is what really allowed the work to be so collaborative and meaningful. Next slide, please. To move the work forward, we organized ourselves into several work groups, each focused on a critical area or specialty in some way, shape, or form. And so that included peer recovery supports, revising our family care plans, community response teams, also known as CHARM-like teams, and data, and then family services policy. And so this structure allowed us to focus on engagement and momentum in the work behind the scenes, and then a good feedback loop to bring it to our core team and our leadership team to make decisions. Next slide. One of the first steps that we embarked on was mapping the current landscape. For instance, where are peer recovery coaches already engaged? What are our community response teams doing well? Where are there gaps regionally? This mapping effort across topics helped us understand what's working, where we have opportunities for expansion and consistency. Next slide. The Family Care Plan Work Group reimagined how we use and how we talk about family care plans, centering the parent's voice, giving them control over who sees what and when. We also piloted a secure virtual forum, engaged birthing hospitals, home health, and others to strengthen community continuity into the postpartum period. And I'm purposefully being very brief on this slide because I know we're going to take a deeper dive in the next presentation with Katie and Kayla into the family care plan work. Next slide. The community response team group mapped the key participants, designed a decision-making framework, and is aiming to ensure that teams across the regions reflect shared values, even if resources differ community by community. So to give a glimpse into what this looks like statewide, about 5 regions have active community response teams, about 4 regions have inactive community response teams, and 3 regions have never had one. And so this regional variation and reliance on the voluntary leadership reflects both a strength of Vermont and then also an indicator of the fragility of our community response team model. And IDTA gave us a really nice opportunity to assess the landscape and begin shaping best practices to strengthen and sustain these local collaborations. So you will see that Megan is the lead for this group and her email address is listed there if you would like to get involved. There's lots more to come from this work group and some good stuff that will be released soon. Next slide. The data work group focused on how we track and share information related to prenatal substance exposure across systems. As you might imagine, the data element is critically important, but it can also be overwhelming based on some of our antiquated systems, the creative workarounds that we create, and the inability for most of our data to interact and talk to each other across systems. Sort of most excitingly, we developed a statewide data inventory and a new portal to gather family care plan and CAPTA data in one place, aiming to improve that coordination and service delivery. Next slide. For the family services policy work group, so this is within the child welfare lens, we chose this image of a winding road pretty intentionally because this policy journey hasn't been linear, but the analysis and the support through IDTA has been deeply important. And so IDTA provided some critical help and support, helping us review national child welfare policies, connect with other states like Connecticut and Oregon and learn from them and learn what we can take away from them. and also flesh out the difference between what belongs in formal policy versus what's best suited for either a practice guidance or a tip sheet type of document. We dug into our structured decision-making tools and looking specifically at how we identify caregiving dangers related to substance use and how we partner with families on creative prevention-oriented safety plans. We also identified the need for additional guidance for Family Services Division staff around breastfeeding in the context of substance use disorder. And through district level data, we explored how drug testing is used across Vermont in FSD district offices, and we faced a disruption in our contracted testing services in the middle of this work. And so it both pushed us to strengthen our behaviorally specific assessment skills, and a lot of this work remains still in motion and still in progress. So IDTA laid the foundation, but our policy refinement and implementation conversations are still ongoing. Next slide, please. So one of the most important, most exciting aspects of IDTA, and something that we were really most jazzed about, was the fact that we were able to do a deep dive into practice across systems in both St. Johnsbury and Rutland. And so rather than focus on any specific takeaways that are specific to those regions, I really want to emphasize the relational power of the walkthrough process itself. So we brought together leaders and frontline staff across all of our respective domains. So the medical community, treatment, recovery, child welfare, and community systems, all in the same virtual room to unpack how decisions are made and how protocols actually play out in real life. And so one of the most impactful aspects of the introduction and the instructions with those system walkthroughs was the emphasis on it's not about what your policy says you do or says you're supposed to do. It's about what is actually happening on the ground and what happens relationally across the different roles. And so the walkthrough took us through a detailed analysis of if this happens chronologically, then what do you do from there? Or what do you do next? Moving through system by system, step by step, and real life processes across the systems. So it was time intensive, but incredibly impactful. The real value came in hearing the why behind each of the questions and the responses, and witnessing those moments where someone said like, oh, well, now that you mention it, we could revisit that, or we could do this a little bit differently. It was that kind of openness to improvements, which is where, the TA really helps. And ultimately, this was a deepening mutual understanding of everybody's roles and what's happening behind the scenes, how and why decisions are made, and where there's openness to change and revisiting the way that we do things together. Next slide. And as far as what comes next and how we continue to partner. So our IDTA has formally ended, but we are committed to the work continuing. Our work groups will keep meeting. We'll continue focusing on our work plans and our goals. And we all remain committed to centering family voice, evaluating our progress, and continuing this collaboration long-term. Really, the partners engaged in this work has been the magic behind all of it, and trying to break down those barriers across systems and how we improve and how we work together. Next slide. And so Elisa and I did not necessarily talk about how we were wrapping up our little presentation, but we wanted to provide you with our contact information. And I'm actually not sure if there's time for Q&A now or if we're saving that for the very end, but I will pause.
That was wonderful. And you guys have plenty of time for question and answer. So I would love it if people feel comfortable, if you want to go ahead and unmute, ask a question, raise your hand, put it in the chat box, whatever works. But this was quite a project, and you guys did an excellent job covering it in such a short period of time. So we'll open it up for questions. So I see a question directed towards Lindsay. Lindsay, what are your thoughts about why there are fewer children in DCF custody over the last few years? Any insights?
Sure. Yeah, I have lots of thoughts. We've spent a ton of time assessing and really unpacking that data. And I think the best explanation, unfortunately, goes back to a few tragic moments in DCF history, where a number of years ago, we experienced 2 child fatalities within a relatively short amount of time that received a high level of media attention, public scrutiny, legislative action, and really just a heightened community response where huge sweeping policy changes were made based on a single event rather than system learning. And so we experienced what's often referred to nationally as a foster care frenzy, where that created an environment where our staff and systems around us, so that was both mandated reporters and folks in the community, started increasing reports of abuse and neglect, and our aversion to sitting with risk really shifted. And so you can see the direct correlation. I didn't quite go back that far in the data, so this is beyond 7 years ago. But in the data, you see an immediate uptick in huge custody numbers following those fatalities and the public scrutiny and attention. And so gradually, we have been attempting to sort of level that pendulum swing, remain focused on our structured decision-making tools, consistency across districts and how we're defining danger, attention to safety planning if there is a danger, prevention efforts of working with kin and creative solutions to how we keep families together, and really just gradually chipping away at, I think it's on both ends, right? It's also looking at the front door of the system and how families are coming to us and coming in, and then also looking at intentional reunification and safe case closure, and how to close cases and support families outside of DCF involvement.
And I think that's a really good point, Lindsay, that you brought up, and that not everything that DCF does is related to change of custody, and how there's a lot of family support, both preemptively when able, as well as lots of family supports that can be accessed as families continue to navigate the process of reunification. And I've certainly been involved in a number of cases as a pediatrician, and it's really good to see that focus on supporting families to stay together. And then here comes another couple of questions. So I'll read this to you. So Lindsay, when reflecting on those system walkthroughs, could you share a couple of examples where interpersonal interactions between patients and providers or among care teams may have influenced deviations from the intended care models? Particular interest in recurring patterns IDTA observed across both clinical and community settings rather than specific cases. That's a pretty full question.
It is a big question. And so I will start, and I will encourage Michelle and Elisa and others from the IDTA team to join in. And so the beauty of the system walkthrough is that there's no case-specific content that's covered, and we really walk through it. So this was facilitated by the National Center, and they had a really beautiful way of asking pretty routine questions that apply across every state system. And, our team did a tiny bit of translating in terms of like, oh, that language doesn't make sense that here, this is what it means here. And it really walks through from the client, from the person with lived experience perspective, and how they're interacting with systems. And so I think, and I'll let others chime in, but I think from my perspective in the child welfare systems hat, I think it was really enlightening to hear about the different screening protocols and models that different OB offices or providers are using. And I think that's where some of the most interesting, just understanding, right? Like how a provider might respond in the moment when working with someone versus how referrals might be made, and sort of how decision making occurs throughout supporting someone throughout their pregnancy. And I suspect once it came time to, once we got to the place where someone is either making a CAPTA notification or potentially has child safety concerns and is making a report, I think digging into how do we get, at our centralized intake and emergency services, how are our staff, asking additional questions? What's the screening guidance we look at? The types of questions, we ask in terms of, what has prenatal care consistency looked like? What are the supports wrapping around a family? Like really trying to flesh out not just the risks and safety concerns, but what are the protective factors? And how does that influence decision-making and whether or not we accept that case? And again, for each decision point, it's walking through if this, then that. So we might go down the path of it not being accepted. We might go down the path of if it is accepted, and then what that means, what happens during the course of an assessment, and then what does closure of that assessment look like? What are workers thinking through as they're doing a required home visit, as they're engaging with birthing hospitals and asking particular questions, and so on and so forth. But again, I have the child protection sort of hat and system focus, so I would encourage Elisa and Michelle to chime in too.
Thanks, Lindsay. I mean, I think the most remarkable part of the walkthroughs was just connecting all the players together. And in some places, that people seem to kind of know the people who came before and came after, but not necessarily across the whole system. And so it really, brought some perhaps non-typical partners that work together in the community into the same space. And for those of you who were able to participate on one, LaTanya is an exceptionally skilled facilitator, and you could really just feel the flow. And so it's harder. I mean, there were certainly concrete lessons learned and some shifts in practice that happened. But I think from my vantage point, it was also sort of connecting all these dots with the patient and family at the center, and really looking at it from that point of view and what that experience is like. And so there was, in addition to bringing these partners together, hopefully some shift in how people are looking at or the point of view in which they're coming at this. So, yeah, Michelle or others, anything to add?
Yeah, I would say the walkthroughs were quite an experience, and keeping in mind that people were joining for 3 hours at a time, it was quite a process. And I would say there certainly was some variability that we were able to kind of not just bring up, but really work through. So I think that was kind of the beauty of the walkthrough, was if there was some sort of policy, let's say on testing instead of universal screening for substance use, that was one area that was identified, and really understanding where that came from and what the risks were people. And again, Lindsay brought this up nicely, like, again, understanding that there is a level of of risk that we can sit with our discomfort and understand that maybe screening and connecting to supports is the best way to help mitigate risk rather than having like a biochemical test. And I think there very much was just really nice conversation among all the different providers on, you know, hey, what screening tool are you using? How is that documented? Where does it go? And I think that was a really wonderful way to look at this. And it did lead to changes, and it also led to a better understanding for us, the variation around the state. And I do want to bring up in the chat, we had a couple of other things come up, and I really wanted to also mention, you know, Jennifer did a nice post here from Central Vermont, and they're really working on strengthening referrals to PCPs. And that we've talked about a lot for pregnant individuals as they transition into that postpartum space where there's no longer frequent check-ins anymore with their obstetrical team. Like, how do we transition them over to a long-term primary care provider? And I love that, having a warm handoff with the PHSO staff to make those linkages. And then there was some comments around the community response teams and the differences among regions and how that is managed throughout the state. And then our wonderful partner, Katie, who I'll introduce here shortly, shared out funding opportunities within the Family and Child Health Division to look at sustainability of CRTs. And that's part of work that came out of IDTA and some additional funding. And again, and I do want to say to everybody in the St. Johnsbury region and the Rutland region who worked with us on these walkthroughs, thank you so much. It was a lot. I agree with Farah as well that we should definitely think about presenting this regionally, because this was quite an undertaking, and it was a really broad team that really came together to support families. So I just want to thank everyone for participating in this work, for continuing this work, for involving us in this work, and for all of you who are submitting questions, because we love to have a nice, lively discussion after each one of our talks.